Hi, it's Jenny B, NSWOC, and today our topic is on venous leg ulcers. So what is a venous leg ulcer? Well, it is a leg ulcer that, or chronic venous insufficiency, is the thing that will lead to a venous leg ulcer. There's lots of potential causes, which we'll go through, but again, the biggest piece is to understand that the treatment doesn't matter what it is that we're going to be putting on the surface of the wound, because the primary treatment is compression and compression therapy. So approximately 40% of women, about 20% of men suffer from chronic venous insufficiency or CVI. And again, they do think it's actually quite low for 25% for men, because again, it's just they don't tend to talk about those things and until there's an actual problem and they're actually at an ulcer. So of that percentage, so if we say 40% across the board, about 2% of those will eventually turn into an ulcer. Usually they have the chronic venous insufficiency for about 5 years prior to actually developing it. Venous leg ulcers too, the biggest challenge with them is about 70 to 80% of them reoccur, mainly because people stop wearing their compression and think, oh, it's healed, it's all better. They don't realize that when they do have chronic venous insufficiency and develop these leg ulcers, that they now will have to wear compression for life. So it'll always be going on in the morning and coming off at night. So what happens with it? I often do my little vein here, that if the shaft of the vein is my arms here, and these are the valves in your veins, what happens is with chronic venous insufficiency is that over time, with weight, with pregnancies, with sitting, standing for long periods of time, even if there's a hereditary element, the veins itself, the walls kind of start to sag, and the valves are no longer together and able to sufficiently pump the blood up. So they do this. One of the things that we do note with chronic venous insufficiency is what happens, and how I know this is happening is something called hemosiderin staining. I'll share that in the next slide. So what happens is, as those veins are down and loose and the valves aren't able to pump the blood up, hemoglobin actually accumulates in the valves, right in the little pockets here. Instead of it being pumped up, the hemoglobin sits in there and it dies. Hemoglobin only lasts approximately 120 days. So with the death of that, there is iron that's actually attached onto the hemoglobin. That iron is then deposited onto the skin, and it looks like brown staining or hemosiderin. So that's how we're able to tell, for the most part, that that's part of the issue, is the chronic problem. So again, there's they can happen through spontaneous. So this is what hemosiderin looks like here. This is this brown spottiness. It's not a nice tan that they think, oh, well, I just had a tan. I've heard that quite often from people, but it's actually this problem where the valves in the veins have become incompetent, and it's not able to, the hemoglobin dies and not able to get back up and process through the body like it would be normally. So the biggest thing for this is I want to show is the appearance. So often they're actually very irregular in shape. They're located at the lateral or the medial malleolus. You're always going to have this hemosiderin staining present. The foot is usually warm. You can usually palpate a pulse. And there's the wound is quite exudating, so they're often red, or you will see sloughy pieces in it. You often don't see any necrosis. And again, there is usually edema present, usually just localized here. Sometimes it is throughout the leg, but usually kind of mid-leg down. Often they have the appearance of an inverted champagne bottle leg, so where there's a really skinny ankle and a really thick calf. And again, the pain will decrease with elevation. Another feature with a venous leg ulcer when it's chronic is, in this one, you're actually going to see something called lipodermatosclerosis. So what that is fibrotic changes or a woody fibrosis. So it's where the tissue becomes extremely hard. And that's when I know that they've actually had this CVI for a very long time, because it's been untreated. So what happens is the skin actually really hardens. They develop this scale, and the hemosiderin actually becomes almost completely covered on the entire leg. The scale, again, can or can't be removed. It depends if they do have a dermatitis that's coupled with it. And this often happens due to an ineffective calf muscle pump. 90% of our blood return is in pumping that calf muscle. So when you see people that kind of walk like a penguin, they're actually not igniting their ankle reflex, and they're not then pumping that calf muscle. So they can end up with venous leg ulcers. It's one of the most common things I do see. So I'm always watching the way patients walk when they're coming in and out of clinic. And due to this, again, that they can have a fixed ankle. So if they've had any ankle injuries, that's one of the reasons that this can happen. So again, watch that calf muscle pump. And again, there's often this red or slough, and there's no necrosis. So again, with this ineffective calf muscle pump, that's when we need compression bandages. I will link below in the video the difference between short stretch and long stretch bandages and why we're choosing them, as well as the applications of them is in there as well, so that we are know how to apply these bandages on coeasily. So there are additional causative factors that we should note as well. So anyone that's had a CABG or a coronary artery bypass graft, they do a venous graft with this. So they'll actually remove part of that vein to do the bypass on the heart. So that patient should also be wearing compression for life. I often see these people from 5 to 10 years later that come back into clinic with a rather large venous leg ulcer. That's because they've taken the great saphenous vein or one of the larger vessels, and it's now been removed, and the smaller veins aren't able to sufficiently pump that blood back up. So it is one thing, if you do know anyone that does have a CABG procedure, they should have some sort of light compression, even if it's just an over-the-counter sock, 15 to 20 milligrams of mercury. And again, that should be for life. Any old traumatic orthopedic injuries, I do see quite a few here because we are kind of a trauma center for orthopedics, because we do have lots that come into our doors. And I do see them that, when they've had an MVC or some sort of large break in one of their long bones, or even in the tibia or the fibia, that later on they can have issues with the veins as well. So again, traumatic injuries are another reason that they probably should be wearing compression ongoing. Obesity, this can also be coupled with lymphedema. So lymphedema can eventually turn into some venous insufficiency. So be aware of that it can be just that the two of them, and the treatment is the same. They both do require compression. Again, multiple pregnancies, or someone that's had twins or triplets, they can actually suffer from this later on in life. And again, if they've had a previous deep vein thrombosis or DVT in the leg, and we do know it is actually quite safe to compress DVT, especially well after the fact, that can actually help with prevention. Immobility is another big piece. So elderly people, if they're not up and moving quite a bit, and they're sitting, especially in a chair, or they're sitting upright to sleep even with their legs down quite often, they can also develop this as well. And then sitting and standing for long periods of time, people that, as I said, I think I've said before, chefs, or people that are, standing in a kitchen or standing, on a line somewhere for long periods of time, they also can suffer from this as well. I will do another video to help denote the difference between venous leg and then cardiac related edema, because it is another phenomenon that helps. Compression is, again, one of the primary treatments, but I want to differentiate quite clearly the difference so that you're able to see the difference between that and a venous leg ulcer. So again, the best compression is the one that the patient will wear. It doesn't really matter to me which one they're in, as long as they're in something. Something is better than nothing. Again, sometimes it does really take your negotiation skills with the patient to be able to say, let's try this. Let's see what the difference is in the wound just by trying some light compression first. I always do, especially if there is some trepidation with wearing it. But a true venous leg ulcer will actually feel better immediately when you've put compression on. Most people find that it hugs their leg, that they're actually feeling some relief from any of the achy pain that they get in the leg. An arterial wound is going to be much more sharp pain that's within the foot, where the leg, with the venous leg ulcer, it's usually the entire leg. So compression actually usually feels better. It is one of the bad things that you can do in wound care. It's the thing that scares nurses the most, is putting compression on an arterial leg. For the most part, as long as you've got a good pulse, a good palpable pulse, you should be doing your ABI still. Although there is, Gary Sibbald has been saying that, again, if you're via Doppler waveform, you're getting a biphasic waveform, you are okay to compress because you know you're going to get adequate flow. So there's still the jury's still out on whether or not we're standardly doing the ABIs any longer, but just to be aware that, again, a good Doppler or a good strong pedal pulse is a good reason to apply even just light compression to start. Okay, hopefully you find that helpful, and again, just remember, the best wound is a closed one.